Let's focus in on synovial joints and talk about the way that they move. When we were in the classroom, I used to have a special quiz on movement, and it was a performance quiz. Everybody had to stand up in the anatomical position, and then I called out movements. And it was an all or nothing quiz. We did it like Simon Says. You had to do everything Simon. I was Simon. We called it actually the Great and Powerful Oz Says. But you had to do exactly the movement that I called out. If you failed, you had to sit down. And at the end of the quiz, whoever was standing got 10 points. Whoever was sitting got 0. So you guys are off the hook on this because we can't really do this easily online. But it's still very important to know the movements because these are standard movements talked about by all medical professionals. And especially, oh my gosh, if you were to go into orthopedic surgery, if you're going to become a physical therapist, you have to know the movements of the joints. So let's start talking about them. First of all, flexion decreases the angle between articulating bones. So remember the nightmare of 10th grade geometry? Remember you had a right angle, you had acute angles, you had obtuse angles. So basically what happens is, if the angle becomes more and more acute, that's called flexion. We decrease the angle between articulating bones. So look at the elbow joint. You can see there flexion of the elbow. Shoulder joint is kind of a little arbitrary. When you move your arm forward, that's considered to be flexion of the shoulder. When you move it back, that's extension. We'll see extension coming up in just a moment. The knee joint, you can see flexion of the knee. That's, in other words, that's bending your leg at the knee. So the opposite movement of flexion is extension. That increases the angle. That's where the angle becomes more and more obtuse. So there's also a special term here if you go beyond anatomical position, that's hyperextension. So look at the shoulder joint. Moving your arm forward is flexion. Moving it back to anatomical position is extension. And if you continue to move it back, that's hyperextension of the shoulder. Hyperextension is still extension, it's just a special type of extension where you've gone past anatomical position. So your shoulder joint, very easy to both flex and extend and to hyperextend. And look at your hip joint, yeah. So when you kick forward, not at the knee, but with your whole hip, that would be flexion. When you bring back to anatomical position, that's extension. When you like kick behind you, again with your whole hip, not your knee, that's hyperextension. So notice shoulder and hip can both easily hyperextend. What about the elbow and the knee? Do those hyperextend? No, not without a lot of pain and most likely some surgery coming up. Look at the atlanto-occipital joint, and we now have to know the technical names of the joints because we're studying the joints. So atlanto-occipital is the joint between atlas and your occipital condyles. So notice if you bow your head forward, that's flexion of the atlanto-occipital joint. Returning to anatomical position is extension. And if you're going to look at something on the ceiling, you would have to hyperextend your atlanto-occipital joint. Then look at your wrist as well. So if you, in anatomical position, if you move your wrist towards your face, that would be flexion. Back to anatomical position be extension. And if you move your hand, move the wrist with your hand then pointing towards the back of your body, that would be hyperextension of the wrist. Okay? So I want you to know these motions. We will have, they will show up on quizzes and exams. I'll expect you to know these movements. Abduction, adduction, and circumduction are more movements of synovial joints. So abduction is movement away from the midline. In Latin, the prefix ab means away, and duct means to lead. So abduct means to lead away. So notice in the lower left, the shoulder joint, if you have your hand down at your side and then you move your arm up straight to the side, that would be abduction. Then bringing your hand back and resting it on your thigh, that's adduction. So that's the next one here, adduction. In class, often, it can be hard sometimes when I'm saying abduction and adduction. People are always going, wait, what did you say? So sometimes when we teach this, when we say it out loud, we say adduction. So I would say abduction and adduction. But since we're not in class, that doesn't really matter. Then circumduction means moving the distal end of a body part in a circle. So Take a look here in the upper right. You can see it's kind of like when you're doing the hokey pokey. You know, you put your right foot in, put your right foot out, put your right foot in, and you shake it all about. Circumduction is going around in a circle. You can see then the top also on the right, circumduction of the shoulder means moving it in a circle. Look also then at the upper left. You see abduction and adduction of the hip. And then to the right of that, you can see the metacarpophalangeal joints. Where would those be? Those are the joints between your metacarpals and your phalanges, in other words, your knuckles. So when you take your hand and move all your fingers together, that's adduction of the metacarpophalangeal joints. When you spread your fingers, that's abduction of the metacarpophalangeal joints. And then notice the wrist itself can either abduct or adduct. So in anatomical position, if you point your hand towards your leg, that would be adduction. Moving your hand away from the leg would be abduction. And there are a few more special movements. Rotation rotates a long bone around its longitudinal axis. So notice in the upper left, the shoulder. So if you have your hand on your stomach and then you move your hand out to the side, that's lateral rotation. And if you get from there, if you move it back on top of your belly button, that's medial rotation. So notice in this case it's your shoulder that's moving. It's actually your humerus is rotating, all right? You're not moving your elbow. Your entire humerus is rotating. So that's rotation of a bone around its own longitudinal axis. Inversion and eversion are movements of the soles medially or laterally. So when you turn your sole inward, that's inversion. When you turn your sole outward, that's eversion. That's the classic way that people sprain their ankles. Which one is more common? Which is the more common way to sprain your ankle? Inversion or eversion? Yeah, inversion. Volleyball players, basketball players, you go up, you jump up to do something, somebody bumps into you, you come down off balance, your foot turns inward, you invert your ankle, and that's often the source of a sprained ankle. Notice, by the way, for rotation in the lower right, your atlantoaxial joint. We looked a moment ago at your atlanto-occipital joint. That's where you could have flexion, extension, and hyperextension. The atlantoaxial joint, that's where atlas and axis come together. So remember, atlas rotates around the dens, or the odontoid process of axis. That's how you shake your head no. Turn your head from side to side. You're literally rotating atlas around the dens of axis. And then dorsiflexion, that's standing on your heels, so pointing your toes up in the air, whereas plantar flexion is standing on your toes. So those are two types of flexion of the foot. And then finally, supination and pronation. Supination is where you turn your palm to face up. Remember, like the supine position? An easy way to remember that is when you supinate, you can hold a cup of soup in your hand, all right? Whereas when you pronate, you turn your palm face down. Remember, your ability to do that comes from the radius rotating around the ulna. That's because you have an interosseous membrane. Remember what kind of joint that was? That was a fibrous amphiarthrosis. Got to put all these together, you guys. I know it's all new and weird terminology, but that's kind of what we're doing here. We're learning new terminology and learning to be able to use it. A few more special movements here. Protraction and retraction, where you move a body part either anteriorly or posteriorly. So in the upper left, you can see the mandible protracting and retracting. That's Elaine Maria, by the way. She's the author of your book. She's an RN and a PhD. And then also notice elevation and depression. So you can elevate your mandible. That's what you do when you close your mouth. Depression of the mandible is when you open your mouth. So notice when you chew, you're alternately elevating and depressing your mandible. Another common body part you can do that with is your shoulder, basically your scapula. You elevate or depress. So when you shrug your shoulders, you're elevating your scapula. All right? And then another one, opposition. This is where you can touch the thumb towards the palm of your hand. So humans are said to have opposable thumbs. A lot of animals do as well. Raccoons can do that. All the monkeys can do that. But some animals can't oppose their thumb. So think of a dog or a cat. They can't touch their other fingers with their thumb. Having opposable thumbs makes your hands much more useful. That's why, dogs and cats pretty much just run on their hands. They don't use tools. The fact that we can do that is why we have such versatility with our hands. It gives us the ability to do a lot of things. Okay, let's talk about injuries to joints. So remember the difference between a ligament and a tendon? Yep. A ligament holds bone to bone. Tendons hold muscle to bone. That's going to turn out to be the key factor in differentiating a sprain from a strain. So let's take a look. A strain is the overstretching or tearing of a tendon or muscle. So like, when an athlete says that they pulled their hamstring, that's technically a strain. That's a tear in the muscle or in the tendon. Remember, a tendon is really part of the muscle tissue. That's why it's so easy to remember. So if you either tear the muscle or the tendon, that's called a strain. On the other hand, if you overstretch or tear, and by the way, for a strain, it could be overstretching or tearing. Same with a sprain, overstretch or tear. If it's a ligament, then we call it a sprain. So like a sprained ankle, we just talked about before, inverting your ankle. You're normally going to stretch or tear ligaments. So that's the difference. Strain, tendon or muscle. Sprain is a ligament. Now, both of these can be classified by their severity. So grade 1 means a mild overstretching or just a very, very slight tearing. That's grade 1. Grade 2 is where it's partially torn but still intact. You didn't tear it all the way through, but it's a pretty good tear. Okay, that's grade 2. Grade 3 is a severe. That's where you tear it all the way through. So grade 1 and grade 2 normally can be fixed just by resting. Grade 3 is going to take surgery. They're actually going to have to sew it back together. The standard treatment for both is RICE. That's rest, ice, compression, and elevation. And I want you to know that. Rest, why do you rest it? Because you injured it, you dumbass. Don't stand on it anymore. If you sprain your ankle, get off your feet. Alright? Otherwise you'll just injure it more. Ice, what's the point of ice? That's to reduce swelling. Compression, what does that mean? Well, like in the lower right, an ACE bandage. What's the intent there? What's the purpose? Once again, to reduce swelling. By putting pressure, you force the fluid out of the area, allowing your lymphatic vessels to take it up and return it to your blood. And then elevation, once again, the purpose of elevation is to reduce the swelling. That's so that all that fluid, all that edema, can drain away into your lymphatic vessels and ultimately return to your blood. So why, in the bottom center, do I have a picture of baby lima beans and organic sweet corn? Well, a lot of times you'll see in the lower right, people get a sprain or a strain and they go get, a baggie or a washcloth, and they get a bunch of ice cubes and they put it on there, and that makes a mess, doesn't it? You end up with water all over everything. So what you do instead is go to the freezer and get out some frozen veggies and put that on there. That will help reduce the swelling, and you'll also be defrosting your dinner at the same time. And what would you be making if you put those two things together? Baby lima beans and organic sweet corn. Wouldn't have to be organic, but lima beans and corn. Anybody know what you call that? That's a nice traditional southern dish. Mix those two together with some butter and some salt and some pepper. That's succotash. Yeah, succotash, good. It's even kind of like heart healthy, good. Veggies. And you know who that is? That's Sylvester the cat. And why do I have a picture of him? He's a cartoon character, and his favorite expression was "sufferin' succotash." As a little kid, I just watched cartoons like crazy. I love Sylvester. He was awesome. So what's the deal with your thumb? Oh, it's just a sprain. Oh, okay, I guess that's not so bad. Oh, yeah? Which hand do you wipe your butt with? It's amazing how things like this can have a huge impact on your life. So, over 20 years ago, oh my God, over 20 years ago, no, as a matter of fact, 34 years ago, I was riding my bike. I was a graduate student back then. Riding my bike, and it had been raining that day, and I loved to ride my bike really fast. So I was riding my bike really fast. I lived in some condos back then. This was in Santa Barbara. And I was making the turn into the condos, and a car came up to leave the condominium complex. And the person in the car looked left, they looked right, and then they stepped on the gas, and they pointed the front end of that car right at me. So I had two choices, either to get smashed by the car or to hit the deck. So that's what I did. I went down with my bike, and as I fell, I put my hand out to break my fall, and I really smacked my wrist hard. But I figured, it wasn't too bad. It was kind of sore. I figured it was just, a sprain or a strain. So I let it go. A week, 2 weeks, 3 weeks. And then I could tell I was getting strep throat. My son and I used to pass strep throat back and forth to each other. So this was when I was a grad student, so I just went to the University Health Center. It was great. It was all free. So I went in there to get swabbed for a strep throat. And while I was waiting, I said, I hurt my wrist. I think it's just a sprain. Would you guys mind, why don't we x-ray it? And they said, okay. So I got my swab for my strep throat. I had strep. They gave me some antibiotics. And then the doctor pointed at me. He came out where I was sitting, pointed at me. He says, come with me. We went back into a room, and he put my x-ray up on they had this big lighted panel they use. You may have seen that before. And he said, look at this, you dumbass. And as it turns out, I had completely snapped my scaphoid in half. And because I hadn't paid any attention to it, I hadn't done anything about it, I just went 3 weeks of continuing to move my wrist. The two halves of the scaphoid had completely rotated around inside of my wrist. And so the guy sent me to a hand specialist. And I was really lucky because at that time, there was a hand specialist from LA who was doing pro bono work. He had like a weekend cabin up in Santa Barbara. So he would come up and he was doing some pro bono stuff at the health center at UC Santa Barbara. So he was the guy I ended up getting. And man, did I luck out, because he was actually, his entire practice was just hand surgery. And he was a sports orthopedic guy. So he did like the Lakers and the Dodgers. And back then it's when the Raiders were in LA. So this guy was a total pro. So he looked at my x-ray and he said, yeah, that's kind of bad, but he had me move my hand. I still had pretty good what do we call it? The amount of movement in my wrist, range of motion. He said, tell you what, we're going to put a cast on it, and for like a month, and then we're going to assess your range of motion again. So we did that, and after we took the cast off, my range of motion was shot to hell. So he said, it was worth a try, but what's going to happen now? I'm going to go in and re-break it, because it had fused back together. I'm going to go in and re-break it, and then try to position it better. You'll have to have your hand in a cast for another 6 weeks, but then it should be okay. So that's what happened. So overall, I had my hand in a cast for 10 weeks, like 2.5 months. And during that time, so the very first time I got the cast put on, I went home and I started typing. And I got to the end of the first word and I went to hit the space bar, and that's when I discovered that I was a right thumb space bar person. And with the cast on, my right thumb could not get to the space bar. So I had to sit down and have a little talk with my left thumb. I said, left thumb, I know you've been on the bench your whole life, but now's the time. You're in the game. This is your moment to shine. So my left thumb learned how to do the space bar and got to be pretty good at it. And then after 2.5 months, when I got the cast off, I typed my first word, and I got to the end and it went ba-bump. You see, my right thumb had never forgotten that it was the space bar guy, but now the left thumb knew it as well. So I had to sit down and have another talk with my left thumb and say, thanks, buddy, you really helped us out, way to go, but it's time to go back and sit on the bench again. It took like another week to train my left thumb not to hit the space bar. Okay, here we go. Which of the following joints is movable? Would it be a gomphosis, a symphysis, a synchondrosis, a suture, or a synostosis? Pause the video, come back when you think you know. Yeah, a symphysis is movable. Remember, a symphysis, what was that? That was a cartilaginous amphiarthrosis. Whereas a gomphosis, a synchondrosis, a suture, and a synostosis, those were all synarthroses. They were not movable. This is the kind of stuff you'll need to know for the quiz and for the exam. You have to know your joints this well, okay? We'll come back and talk more in the next annotated PowerPoint.